Hello all, welcome to today's Kirby Institute seminar series. My name is Mo. I'm a senior research fellow in the HIV Epidemiology and Prevention program and the group lead for the LGBTQ+ population health research group. Today we're presenting from the Kirby Institute, which sits on the land of the Bidjigal people of the Eora Nation. I pay my respect to elders, past and present, and extend that respect to any Aboriginal and Torres Strait Islander people joining us today. So unlike other seminars, in this seminar, you're allowed to ask questions throughout. For the people in the room, use the microphones. For people online, you've got the icon at the bottom, the Q&A icon at the end of the bottom of the screen, but they'll be read out at the end. It's the perk of being here in person. Now, it is my absolute pleasure to introduce today's speaker, Dr. Karinna Saxby. Karinna is a research fellow and health economist at the Melbourne Institute of Applied Economic and Social Research at the University of Melbourne. Her work focuses on healthcare access in Australia, especially among priority populations, which include Indigenous people, LGBTQ+ populations, and people with disabilities. Today, Karinna will be presenting on mental health care use following hormone treatment among trans and gender diverse Australians. Please put your hands together for the incredible Dr. Saxby.
Thank you so much for having me, and thank you for that amazing introduction. And hosting me so well. Okay, so I've got the slides up here. So as Mo said, I'm from the Melbourne Institute at the University of Melbourne, and today I'm presenting, this is quite recent research, which is looking at the mental health treatment among trans and gender diverse Australians following initiation of gender-affirming hormone therapy. And this is joint work together with Tom Bookmiller and Kit Carpenter, who are based in the US, Clue Coleman, who's based here at UNSW, and then Brendan Nolan, who's at the Trans Health Research Group, and he's actually an endocrinologist and is one of the largest prescribers of GAHT in the country, and was actually involved in setting up a lot of the gender clinics on the east coast of Australia. So it's been so wonderful having him involved on this project, and as a result of this, we've got lots of other papers coming out. So it's great to work with him. And before I get started, I also want to acknowledge the traditional custodians of the lands on which this work was conducted, which is the lands of the Wurundjeri peoples. Okay, so just as a bit of background and motivation, I'm sure most people in this group know that trans and gender diverse populations are those whose gender identity doesn't align with what their sex was categorized or assigned to them at birth. And they actually represent a substantial and a growing share of the population. So among adults, it's estimated that around 0.5 to 4.5% of people identify as trans or gender diverse, but this is a lot higher among children and adolescents, ranging from 2.5% up to 8%, depending on what type of samples are used. And, you know, alongside this increasing awareness of trans and gender diverse identities, there's also more data coming out in terms of health and social outcomes. And in particular, a lot of the emerging research has shown that TGD populations experience much poorer mental health relative to cisgender populations. And that's around the world in different contexts and so on. And that's in terms of high levels of psychological distress, self-harm behavior, and suicidal ideation and suicide. And just so you can really get a sense of the magnitude of these mental health inequalities in terms of thinking about data on suicidal ideation, around 43% of TGD individuals have attempted suicide in their lifetime, compared to only 3% in the general population. So these are just profound mental health inequalities. And there's just even some evidence that these mental health inequalities are actually getting worse over time. So this graph that I'm showing here is showing results from the Household Income and Labour Dynamics in Australia survey. It's called HILDA. And this is the largest sort of representative national household survey that we have in Australia. And in 2021, for the first time, they included questions on gender identity. And so from this, myself and some amazing co-authors had a look at what was the mental health of people who identified as trans or gender diverse in HILDA. And then we followed their mental health scores back and compared them to cisgender Australians over this 22-year time period. And essentially what we see is in, you know, between 2001 to 2011 or 2010, you know, consistently TGD Australians have poorer mental health compared to cisgender populations. But in particular, in these past 10 years or so, these inequalities have gotten a lot worse. So we've got these sort of widening mental health inequalities, and we've got evidence now this is happening even in these population representative surveys. And we're seeing that this is not just the case in Australia. We see similar results also in places like the US and in other contexts as well. So really, really profound mental health inequalities in this population, and quite a bit of evidence now that these inequalities are actually getting worse over time. So what is driving some of these mental health inequalities, and in particular the worsening mental health inequalities? Well, largely these are thought to arise from minority stresses as well as stigma and discrimination. And there has been a lot of work coming out, including from the Victorian Pride lobby, that experiences or exposure to anti-trans hate has been escalating both online and in person. And that's in terms of verbal harassment and abuse and physical harassment as well. We also see even in Australia that people are being denied or refused care. So earlier this year in Canberra, of all places, a trans adolescent was denied just visiting a GP, even just because they identified as trans. It wasn't actually to do with any gender affirming or trans related healthcare. It was just a regular checkup, and they said, no, I'm not going to see you. So there's this really blatant discrimination that's still going on even in Australia. And I think, aside from these sort of stigma and driving these mental health inequalities, there's also increasing recognition around gender dysphoria. So not all trans and gender diverse people will experience gender dysphoria, but a lot will. And so it's around 70 to 80%. And essentially, this is the distress that arises when an individual's gender identity doesn't align with their sex assigned at birth. So really, in light of these mental health inequalities, we need evidence on what interventions can help reduce gender dysphoria and try and improve mental health among trans and gender diverse populations. Okay, so in particular for today's talk, I'm really going to be focusing on this medical affirmation, recognizing there's all other sorts of types of affirmation, such as legal and social affirmation, but really the purpose of today's talk is focusing on the medical affirmation for sort of, treating gender dysphoria. And so that's one of the key treatments, and generally it's sort of categorized into these 3 different stages. So stage 1 refers to puberty blockers, and this is generally for people under the age of 16, and they are used to basically delay the onset of puberty or the progression of it by suppressing the production of estrogen or testosterone. These are not available under the PBS. You can get them through these gender clinics that I mentioned earlier, but really it's up to the state. So it's these state-funded gender clinics that you get access to the puberty blockers, or you can pay for them privately. So not subsidized through the PBS. Stage 2, which will be the topic of today's talk, is this hormone therapy. Now, this is subsidized on the PBS. And for people who are seeking feminizing care, it's estrogens and a combination of anti-androgens, which block or reduce the effects of testosterone. And then for people seeking the masculinizing hormone therapy, it's testosterone. So then after that sort of stage, and it is sort of this stage process, the next stage, it refers to the surgical intervention. Now, there are some of these publicly funded, but this is very rarely done. And if it is done, you've got very, very long waiting times, like over a year. So to this end, most patients, if they're seeking surgical intervention, which could be top surgery, bottom surgery, or so on, they might travel overseas to get access to it, or they can get it here in Australia, but they'll be paying privately out of pocket to get access to that sort of surgical affirmation. But that said, there is currently an MSAC review. So MSAC is who appraises whether certain things are cost effective and deemed to be included in the MBS and subsidise that in that way. So there is a review currently underway for surgical medical affirmation, and we really should be getting the outcomes of that decision pretty soon. So we'll see what happens with that one. But as I mentioned today, I'm really focusing on this hormone therapy, acknowledging again that, not all trans and gender diverse populations will access hormone therapy or want to access it. But to note that it is a large share. So some estimates have this at around 72%, and that's in population level samples. And then in a recent survey, which was through the Trans Pathway Studies, and that's on younger people, so 14 to 25 years old, it was 84% who were on or wanted to be on gender-affirming hormone therapy. So it is a large share, so it's important to look at. And just a quick note on the clinical guidelines that I wanted to tell you, because it's going to be important for our results later, is that it is actually recommended that when you initiate gender-affirming hormone therapy, you visit a psychologist. And in particular, if you're less than 18 years old, it's actually mandated. So you have to see a psychologist before you're able to be put on the hormone therapy. Okay, and then in particular, just a bit more around the policy environment and why we're specifically focusing on this medical subsidization, medical affirming care, and in particular the public subsidization of it, is that it's really policy relevant. And I assure you have to really have had your head in the sand to not be sort of across some of these pretty scary stuff, I suppose. But so we've seen in the UK, they've stopped children and young people to be able to get puberty blockers, hormone therapy. We've seen Trump make these executive orders around gender and then blocking funding of gender-affirming care. And then even like earlier this year, we then saw Queensland do something similar where they said we're not providing puberty blockers, hormone therapy for young people with gender dysphoria. So just really strong policy decisions being made with sort of not too much empirical evidence behind them, I would say. And in particular, in response to that Queensland decision, we saw that there's going to be an NHMRC review into the actual clinical guidelines for treatment of gender dysphoria among trans and gender diverse young people. So that's going to be happening. Like they're already starting to form that committee, and that'll be happening later this and next year. So really, in light of all this, I'm really keen to try and get some empirical evidence on this, and in particular to try and find out some evidence around the mental health impacts for young people as well in light of this review. Okay. So in terms of the previous research on gender-affirming hormone therapy, mental health and mental health care, at a broader level, gender-affirming hormone therapy has been associated with better mental health among trans and gender diverse populations. I will say that a lot of the studies have relied on these sort of within individual before-after type trials, or these sort of cohort and cross-sectional analysis. There are some exceptions though. So one study that my co-author Brendan did, he actually did an RCT and found that access to masculinising hormone therapy reduced experiences of gender dysphoria, depression, and suicidal ideation at 3 months. That was a great study. Then there's been a more empirical study, which is focusing on this change in policies where in the US, they made gender-affirming care publicly funded through Medicare. And they found that that was associated with improvements in mental health among trans and gender diverse populations. And then this is another co-author of mine, and it's a working paper actually by Travis Campbell and co-authors. He's found that initiating gender-affirming hormone therapy is associated with reduced suicide risk. And they actually found there was larger effects for younger populations, so those who got access at early ages. However, I will say that this is based on this sort of non-random sample in the US. Pretty good sample size though. And that's not published just yet, but that's a great paper as well. And then in terms of the sort of mental health care use, there's really only one other study that's looked at healthcare use pertaining to mental health. And this is, again, a Swedish population level study. It was based on people who had a diagnosed gender incongruence diagnosis. So it's based on the ICD-10 codes. And that was between 2005, 2015, just under 2,000 people. And they actually found that time since being on gender-affirming hormone therapy wasn't associated with any changes in mental health treatment, but time since medical affirming surgery was. So there altogether is some evidence that this gender-affirming medical treatment is associated with improvements in mental health, and maybe some evidence on, reductions in mental health care use, However, some of the challenges with this is, of course, the sample sizes. They're generally working on pretty small samples. They can't control for these within individual changes in people's mental health care use over time, or other sort of broader temporal factors that could impact mental health and therefore mental health care use over time. So all these factors are really important to control for. And limited population level evidence such that we haven't been able to look at sort of heterogeneous effects across, regimen type, so masculinizing or feminizing, or by age group, things like that. So as a result, that's really bringing us to the aim. So a bit of a long background, but I think it's important to contextualize all this. And really the aim of this work is to try and understand what's the mental health effects of accessing this hormone therapy among trans and gender diverse Australians. Okay, so in terms of the hypothesis, there's quite a lot to unpack in this space. So, at a high level, you're thinking, okay, the evidence suggests that accessing the hormone therapy is associated with improvements in mental health, so therefore it might reduce the demand for mental health care. However, as I mentioned earlier, to actually initiate hormone therapy, you need to visit a psychologist. So you need to be engaging with mental health care professionals. So in that sense, you might expect to see a slightly higher use in healthcare, particularly around initiation. And then at the same time, this is a really crucial times in people's lives. They're undergoing medical affirmation. In some cases, this is not a reversible treatment. So you actually want people to have some mental health support. So, you could take this in sort of both ways of what you might expect to see happen with mental health care. And you also might expect to see different sorts of effects based on the population, so potentially by age of initiation. The other paper by Campbell and others found that earlier access was associated with better mental health. So if that's the case, maybe we see larger reductions in mental health care. Then at the same time, the younger populations, they're the ones who are mandated to actually see a mental health professional before they start. So their use might be higher. So you've got lots of different things going on. And there's also expected to be some differences in terms of the regimen. So whether it's feminizing or masculinizing hormone therapy, a lot of the research is sort of showing that testosterone does lead to quicker and more noticeable physical changes, and that can be really affirming for a lot of people. So generally, the research has showed that accessing masculinizing hormone therapy is associated with larger improvements in mental health compared to accessing feminizing hormone therapy, because the effects of feminizing hormone therapy can actually take a lot longer. So there might be some differences by the regimen as well. So there's lots going on and things that we need to look at separately. So onto the data. The data we're using for this comes from the person level integrated data asset. And this is a whole of population administrative data set. And it's basically lots of different administrative data sets that are joined together. So we've got information on the census, we've got tax records, death records, MBS and PBS, there's social security payments, there's so much information in there, and more is being added into this as we go along. So it's a really great resource. And I think it's a really good way to actually look at this population. Noting, of course, it's not perfect, but I think it's a really good start. So today we're specifically focusing on the Medicare records. So through Medicare records, we have information on all publicly subsidised out-of-hospital medical services and subsidised prescription medicines under the PBS. Specifically, we focus on 2012 through to the end of 2024. That date is very deliberate because I don't know if people have worked with PBS data, but before April 2012, below co-payment prescription medication wasn't recorded in PBS records. So if you look at data before that time, you're not really getting a complete picture. So that's why we have to cut it off there. We then identify trans and gender diverse populations using a combination of the gender marker, and I say gender marker because it's not really a gender marker, with that and a combination of the use of hormone therapy claims in the PBS records. So specifically, if someone had received a testosterone script, but they had a previous or a current female gender marker, that group was defined as accessing masculinizing hormone therapy. Whereas someone who received an estrogen script and then they had a previous or current male gender marker, then they are classified as accessing feminizing hormone therapy. And just really important to note in terms of this gender marker, it's not really a gender marker. So this is not going to be completely capturing all TGD populations, of course not. And people can actually update their gender marker in Medicare. Since 2013, they've been able to do this. But still in the records, it's only provided as F or M still. So we're missing a whole bunch of other gender diverse groups And that's just a limitation of the data. We also do some other exclusions. So we exclude people under the age of 15. And in particular, there's differences in the way people are sort of treated and the way people access mental health care by age. So we just thought it was cleaner to do that. We also exclude people who are in both groups, so alternating, because it's pretty difficult to categorize which group they would go in and also what the date of initiation should be. And we also exclude people who are already receiving hormone therapy in 2012, because we wanted to try and be a bit more clear on that they're actually initiating for the first time, because we can't go further back than Q2 2012. And yeah, as I mentioned as well, we can only see TGD people who are accessing hormone therapy. Okay, so the outcomes data, this is also all in PLIDA. So we're mainly focusing on this healthcare use that's provided through MBS and PBS. Specifically in the MBS, we're looking at mental health care services that are mental health related. That includes GP mental health treatment plans, visits to a psychologist, visits to a psychiatrist, allied mental health, all of that's included and captured within Medicare records. We then also look at prescription medicines and mental health related prescription medicines through antidepressants and anxiolytics. And as an aside sort of through this, we can look at the benefit paid. So that's the government expenditure towards these services. And we can also look at the out-of-pocket costs associated with accessing those services as well. So that we'll look at that briefly today, but that's also sort of some of the work we're planning to look at in the future as the out-of-pocket costs associated with accessing this care. And then we have these sort of placebo outcomes. So this is a sort of economics term, but it's basically outcomes that we expect to be less impacted by mental health when they initiate hormone therapy. So specifically, we look at medication for diabetes, and then we also look at hypertension. So this is more of a placebo for people who are accessing masculinizing care, but actually for people accessing feminizing care, one of the key anti-androgens that's prescribed is actually an antihypertensive. I can never pronounce it. It's like spironolactone or something like that. So it's actually more of a check that we're getting the right population actually in this sense, because we expect that to actually go up when people initiate feminizing hormone therapy. Okay, so that's all the outcomes we look at for in terms of healthcare use. And then we do a separate analysis, which is sort of a bit of an add-on, and I think it won't actually be included in this main paper, and it'd be interesting to get your feedback on it. I think it might be a separate second short paper. And that's that we look at a subsample of this group that we're able to link into the 2021 census. And specifically, we do that because for the first time in 2021, they asked a question about long-term health conditions. And specifically, the wording is, have you been told by a doctor or nurse that you have any of these long-term health conditions? Include ones that have lasted for 6 months or more. So it's really these long-term conditions. And there's 11 different conditions that people could select from. Lots in there, but really for today, of course, we're focusing on mental health. So it's they reported mental health condition, including depression or anxiety. And then as our sort of placebo outcomes, so outcomes we're expecting to be less impacted by initiating hormone therapy, we look at asthma and diabetes. Okay, so here's the descriptives, and look at my amazingly large sample. So using that approach that I've mentioned for identifying, I've got people accessing masculinizing care, so testosterone and ever female, over this sort of 10-year period, just over 11,000 people. And then for people who are accessing estrogen and they ever had a male marker in their records, I've got, just over 20,000 people. So really large samples, and these are some of the largest samples, definitely the largest we've ever seen in Australia. And noting that, we have a lot larger sample of people accessing feminizing hormone therapy compared to masculinizing. And that's actually very common with what we've seen in other population surveys around the world. So that's quite consistent with that. Some other important characteristics, we see that when people are first initiating hormone therapy, people initiating masculinizing therapy are a lot younger, so 25 years old, compared to people who are initiating feminizing, around 34 years old. We also look at people who are changing their gender marker in the PBS records, and I think this is really interesting. So we see that among people accessing masculinizing, only 23% of them ever changed their gender marker. Again, not perfect because they can only change it to M or F. So it's not really a perfect way to measure that, but it's still interesting. And then same with feminizing, we see it's around 19% actually change their marker. If we look at concession card status, it's sort of similar, around 17% have a concession card. So people who are potentially on welfare, or that could be a few different populations with concession cards. People living in rural areas, it's quite similar, but only 16% living in rural areas. So largely, these are people who are living in metropolitan regions that are able to access this type of care. And then in terms of the census linkage, we get around 76% that's able to be linked to the census. And from the census, it's actually, again, quite interesting, and I think separate paper, but among people who responded to the census, people accessing masculinising care, 53% of them responded that were male at the time of the census, whereas people accessing feminising care, only 23% said they were female. So and this is again consistent with what we've seen internationally in other research, is that people who are accessing the masculinising care are more likely to sort of socially and legally transition compared to people accessing feminising care. So it's just all quite interesting, quite consistent with what we've seen elsewhere. And then just a little bit in terms of the outcomes to help you contextualise the results. If we're looking at mental health care services per year, it's quite similar around each group. So it's about one mental health service every 2 years. Mental health scripts is a bit higher. So people are filling, 2.4 scripts if they're accessing masculinising care per year. Whereas people accessing feminising care, they're actually filling a lot fewer scripts than people accessing the masculinising care. And I think that is really interesting in and of itself. If we look at long-term health conditions, particularly focusing on this mental health condition there, and again, that's from people linked to the census, you can see that 42% reported a mental health condition at the time of the census among masculinising GAHT recipients, and this was around 32% among people accessing feminising care. So really a really large share compared to the general population reporting a mental health condition. And to tell you, what are some of the other general differences, again, consistent with what we've seen in other studies, the population's a lot younger. They're less likely to be in the rural areas, and much more, despite being younger, are much more likely to report long-term or mental health conditions. Okay. Okay, and then here's a little bit more about the descriptives and what's been happening over time using this data. So what you can see is we've got a very, most of our sample is coming from more recent years. And again, that's consistent with international research. Initially in the earlier years, most of our sample were people accessing feminising hormone therapy. We had a very small share of the sample accessing masculinising care. But over time, that has changed, and we've seen more people are starting to access masculinising hormone therapy. And this increase is in particular dominated by younger people. So it's newer, younger people accessing care in more recent years. Still at the end of the sample, we've got a larger share accessing feminising care. Okay, and are there any questions on the descriptors and everything before I get into the empirical strategy? Yeah, go, Philip.
Can I clarify, or can you clarify for me, just how you're measuring, I guess, poorer mental health? Is it simply accessing mental health services, apart from what you got from the census about the long-term mental health conditions?
Yeah, so that's why this paper is very difficult, because measuring use of mental health care, you could argue it's both ways.
That's what I'm wondering.
It's very hard. And so that's why I'm sort of doing two things. So one is looking at mental health care and splitting it up in terms of services and script use. The other is then looking at whether people report a long-term mental health condition at the time of the census. So that is a self-reported measure. But I agree with you, mental health care use.
Because it could be a good thing that people are,
exactly.
Yeah.
So that's when I show you the results, you can it could be a few different things happening. And I'll tell you what my hypothesis is. But yeah, thank you for that. It allowed me to have a drink of water. Okay. Okay. So now I'm going to go into the empirical strategy. And I know we've got lots of people with different backgrounds in the room, so I thought I would just do a difference in difference design on a page. But for those who haven't heard of differences in difference design, it's essentially a sort of like an RCT, but you're doing it on applied data. So you've got a treatment group and a control group. So you're looking at outcomes before and after some sort of treatment or policy change, for example, and then you compare it to a control group that were not treated over the same time period. So the sort of unique thing about the setup that I'm going to present to you today is that my entire group always is treated, but what I'm doing is I'm exploiting the variation of the time in which they were treated. So if you think about a sample that was treated in 2014, I'm comparing them to people who aren't treated to 2017, for example. And if you think about the 2024 group, because that's at the end of my sample, they're always a control group. I have no pre-post for them. So that's sort of how it works. And I've drawn this little picture here. So that's basically what we're looking at. This is an outcome, and this is an example of showing what happens to someone who post-policy sees an increase in their outcome, whatever it may be. But basically, the most important assumption with this approach is that this difference between your treatment and control group, that difference should evolve in parallel over time, and that's called the parallel trends assumption. And so based on that pre-reform or pre-treatment trend, you predict out what the counterfactual would have been had the policy not happened, and that's how you get what your treatment effect is. So that's this sort of difference in difference on a page for you, but just to note that this control group, they will be treated in the future. So you could sort of imagine that's what's going to happen to them in the future. But the way you set up your model is that you make sure you don't include them. You're just really careful about your control and treatment groups in every single event time. And I really think that this is a good approach for this analysis, because other studies have done things where they're comparing outcomes to, say, the general population or TGD populations who have not received gender-affirming hormone therapy. But my sort of main argument is that, you know, we think those populations are likely to be very different from people who are accessing hormone therapy. And even if we think about the studies where they're comparing trans and gender diverse populations to cisgender populations, you think about things that are happening over time. Of course, there's different things that are happening over time that are differentially going to impact the mental health of these different groups. Look about like some of those policy changes I was just talking about earlier. Like, it's a very strong assumption comparing mental health outcomes over time among trans and gender diverse to cisgender populations because of that. So that's why I think this is a good strategy. It is sort of complicated to think about, but if you have any questions on that, please, we can chat through it a bit more. I'll now show you a scary equation. So this is basically what the empirical strategy is. Sorry. This is the empirical strategy in math form. So it's called a dynamic difference in differences analysis, where we're looking at outcomes before and after initiating GAHT or hormone therapy compared to peoples who had not yet initiated at the same time period. So we're looking at our outcomes, which is mental health care use per year for mental health services and scripts separately. We control for individual specific fixed effects. So that controls for all time invariant confounders that could be associated with mental health. Could be things like propensity to seek care, socioeconomic background, educational background, things that are fixed over time. We control for year fixed effects. So that's controlling for temporal trends that may impact mental health over time for trans and gender diverse groups. And then our main coefficient of interest here is this event coefficient. So we've got this lead and lag of an indicator variable for when you're starting your hormone therapy. So at event time equals 0, that's the year you started hormone therapy. Event time equal 1, it's 1 year after starting hormone therapy. So they're our main coefficients of interest. And specifically for this study, we look at 6 years before initiating and 6 years after, because that's as much as we can do with our data and our time frame. And what we do is we actually reference everything to the 2 years before people initiated hormone therapy. So with these event time coefficients, they're all referenced to, they're all identified relative to some sort of reference period. And we specifically choose the 2 years before initiating hormone therapy because we know from the treatment guidelines that people are sort of mandated or recommended to see a mental health professional before they start. So we want to see if there's that uptick before people start. So that's explicitly why we choose that reference period. We then estimate these models separately for people who are accessing masculinizing or feminizing care. And we also do it separately for each regimen by age group. So there are 15 to 24 years or 25 years and above at the time they accessed the hormone therapy. Then, so that's the main results that I'm presenting today, which is that event study analysis on healthcare use. Then the supplemental analysis that I mentioned might be a separate paper. That's the one looking at the long-term mental health condition. And this is sort of the spirit of a regression discontinuity design, where you're looking at sort of the change in trends of the share of people reporting a mental health condition before or after they initiate hormone therapy. And I know that's saying that in a very complicated way, but if you think about the census date, got the census date for everyone, that's all the same. But at the time that they started, hormone therapy is different for everyone. At the time of the census, we've got some people who haven't yet started, some people who have. So we're just looking at how long has it been since you've been on hormone therapy, and then did you report a mental health condition? So that's essentially what we're doing there. And again, we look at those sort of falsification-related outcomes, which is diabetes and asthma as our sort of placebo outcomes. Now, is there any questions about the empirical strategy before I? Yeah, we'll just go on. Okay, event study results. Okay, so here is the results for people accessing masculinizing hormone therapy. And I'm showing you the number of services or scripts used, again, that should be year, in each year relative to initiating hormone therapy, with mental health services in blue and mental health prescriptions in orange. And what you can see is in the sort of 6 to 5 years before initiating hormone therapy, there isn't too much going on. It's relatively flat. So that means that people's mental health care use isn't changing too much compared to people who are going to be initiating in the future. So that's that parallel trends assumption I was sort of telling you about earlier. And then just before people initiate hormone therapy in the year before, we see there's this jump up in the use of mental health services. And that's quite consistent with the treatment guidelines. They're expected to see a psychologist and so on before they initiate hormone therapy. We don't see too much going on for scripts. But then quite quickly after people initiate hormone therapy, we see there's this significant drop in the use of mental health care services and mental health prescriptions. So at around 6 years after initiating, we see that people initiating masculinizing care, they use around 3 fewer mental health services each year, and they fill around 1 fewer mental health scripts each year as well. And so to help contextualize that, that's roughly a 71% reduction in services compared to that reference period, and a 51% reduction in scripts. So really large reductions in mental health care use. And because I'm an economist, I have to attach some money to everything. So this corresponds to $440 less that the government is paying per year per person on mental health care services. So quite significant. And then these are the results when we stratify them by age group. So people 15 to 24 years on the left, 25 and above on the right. And we generally see pretty similar results, these similar trends as well. It's very difficult to tell on this axis, but this uptick in the use of mental health care services is actually slightly higher among the younger group, which is consistent with what we'd expect. If anything, at 5 years here, I can't go to 6 years because I don't have the sample size for it. So at 5 years here, three fewer services. We look at 5 years for the older group, 2.5 fewer. So slightly larger reduction in mental health care services among the younger population. But those confidence intervals are overlapping a lot. So you can't really say too much, but more pronounced. Okay, and then the results for feminizing hormone therapy are similar but different. So again, we see there's sort of not too much going on in the years before starting hormone therapy. There is some slight pre-trends there, suggesting that maybe, before people initiate hormone therapy, they're starting to use a few more services. We see this uptick in use of mental health care services prior to and around the time of initiating hormone therapy. And then the highest number is again, similar to the masculinizing results. It's in that first year of initiation. We see this big uptick, again, consistent with the treatment guidelines. And then quite quickly after that, we see that the use of mental health services drops down as well. So using around one fewer mental health care service each year after 6 years. Whereas for prescription medicines, we actually see that there's this increase around the time of initiation. And then this stays up a bit higher, around one more script per year. And it sort of plateaus at around 2 years, and then it starts to decline. And this is quite interesting as a result, because it's quite different to what we see for the masculinizing hormone therapy. But something that we saw in the descriptives that I showed you earlier on is that when we looked at people's use of mental health care before initiating hormone therapy, feminizing GAHT recipients used a lot fewer mental health prescriptions compared to people who are accessing the masculinizing therapy. So I do wonder to what extent this is actually addressing unmet need in this population. But in particular, given we see that there's sort of this increase and then it's going down, could suggest to us that we are seeing improvements in mental health with longer time since initiating hormone therapy, which would be consistent with what we see in the other research as well. And I do think that initial uptick is capturing some unmet need potentially. And then, important to note as well, at 6 years, that is no longer statistically significantly different. So it's already dropped down to at 6 years. And if we attach financial value to this, at 6 years, it's $100 less in government expenditure per year per person. And in part, that's important because, mental health care services are a lot more expensive than mental health scripts. That's still why it's, still why it's a significant reduction in costs. Yeah. Okay, and then when we look at the stratification of this by age group, we can see that increase in mental health prescriptions, it's mainly driven by younger people actually, so 15 to 24 years old. And this uptick in the use of mental health care services, it's a lot higher among young people. So it jumps up to two more services around the year of initiation compared to just over one among the older population. So again, it's sort of aligning with the treatment guidelines, suggesting that there's a lot more mental health support and management among younger people who are initiating. But it's quite interesting that we see that difference is a lot more pronounced for the people accessing feminizing care compared to the masculinizing group. And I think part of this could be that there's been a lot of changes over time, and our sample, in particular our feminizing group, they're a lot older than the other group. So there's a lot of these differences that are coming into play. And so it's a complicated analysis, but we do still see there's this clear structural break. And there's this trend of over time, mental health care use goes down. And if I was able to, had more PBS data, this would go down too. Like you can sort of expect what would happen here. Okay, and then here's one of those placebo outcomes. Unfortunately, I haven't got the results vetted out at the annual level yet, so this is all at the quarterly level. But basically, we don't see too much going on. Like these are tiny numbers. So this is number of diabetes scripts per quarter per person. And, for people accessing feminizing or masculinizing care, we just don't really see anything going on. There's just this linear trend through the whole thing. So it's not accessing hormone therapy isn't really associated with other outcomes we wouldn't expect to be impacting mental health. So important one. Okay, and then here's the results for the antihypertensive. As I mentioned, the number of antihypertensive, it's more of a placebo outcome for people accessing masculinizing care, but it's more of a check for people accessing feminizing. So we see around people initiating this hormone therapy, they're also more likely to have this anti-androgen prescribed and use that. And then over time, we see that reduces a bit and sort of plateaus. And that's quite consistent with what we expect to see as well, that people might even be able to reduce anti-androgens over time or completely stop them once the testosterone is suppressed. So they're just sort of checks. Now, are there any questions about the event study before I move on, or we can save the rest for the end? What's that? Oh, 10 minutes. That's fine. I might just go through then. So then this is the second analysis, which is looking at the census-linked results. So whether people reported a long-term mental health condition at the time of the census. And I'll talk through these on just through figures. Okay, so this is the share of people reporting a mental health condition over time. So this is all relative to the census date. So our x-axis is census date minus quarter that you initiated gender-affirming hormone therapy. So all the people on the left here, at the time of the census, they hadn't yet started hormone therapy. And all the people on the right, they have started hormone therapy, but there's just different lengths of time that they've been on it for. So if we look at the people on the left here, we can see that over time in the years prior to initiating hormone therapy, the rate in which people are reporting a long-term health condition is increasing over time. And then after they initiate hormone therapy, we can see that that trend completely goes the other way. And in particular, we see that the rate in which people are reporting a long-term mental health condition reduces more sharply for people who are accessing masculinising care compared to people accessing feminizing care. However, we still see that rate plateaus. So suggesting that potentially being on gender-affirming hormone therapy is associated with reduction in reporting a long-term mental health condition among trans and gender diverse populations. And then here are the same results when looking at these other outcomes we expect to be less impacted in terms of mental health. So diabetes on the left, asthma on the right, and it's very noisy. We really don't see much going on. So it suggests something is going on with mental health. But again, because this is quite a different empirical design and so on, I think it'd be good to hear your feedback, but this might be a separate paper or something. We have to think about this one a bit more. Okay, so to summarize the main results, after initiating gender-affirming hormone therapy, we see that use of mental health care services reduces in both groups. It's around 71% for masculinising GAHT recipients, 52% for feminizing. Mental health scripts also reduce for people accessing masculinising care, but not those accessing feminizing care. We see that it actually goes up before plateauing and reducing. But this still does correspond to a significant reduction in mental health care costs from the government perspective. So I do this very sweeping back of the envelope calculation, and I just apply these average cost reduction to the sample size we have. It corresponds to a reduction of around $7.8 million in mental health care costs. So I'm really going to be trying to pitch this as an investing to save type situation eventually. And in terms of the census-linked analysis, it suggests that increased time since initiating GAHT is associated with reduction in the share of people reporting long-term mental health condition. There are many limitations with this analysis. Of course, demand for mental health care is a difficult proxy for mental health, as we've discussed, but I think in combination with other empirical literature, I think we can say that altogether, it seems to be that hormone therapy is associated with improved mental health, and that is associated with reductions in mental health care use. We can't observe lots of other things like people who aren't accessing care. Another important thing to note is people under 18, they definitely have support when they access. They have to have parental consent as well. So there's all those sorts of selection effects going on when we think about their sample, and definitely inequitable access across the country. Like we saw that even with the rural-urban divide. And many other changes we can't see, like people accessing surgeries and puberty blockers. We can't see that in our data, unfortunately. In terms of future work, there's a lot more planned to look at the effects of the hormone therapy on like out-of-pocket costs, government costs. We can even look at healthcare use at family members. There's a lot of scope to do lots of different analysis. This is just the beginning, really. Hopefully be able to look at hospitalizations one day. And the Census 2026 should be good because we'll finally have some information around gender identity in there. So really looking forward to that. But just to summarize, because I know we're running out of time, mainly the policy implications is this, together with other empirical research, which suggests that the hormone therapy is likely to improve mental health among trans and gender diverse populations and also reduce government expenditure. And that policies that are restricting access to gender-affirming hormone therapy are likely to have long-term and deleterious mental health consequences. Okay, so that's all from me. Thank you so much for having me.
Do we have any questions in the room? No, I've got one. You had several scripts listed. Were there any other scripts that you considered that were
Yes, of course. So we've done a few different things and looking at a bunch of different outcomes. First of all, with this analysis, we tried with and without including antipsychotics because there's they also fall into the capture of mental health scripts. but we didn't see any difference at all. So then we've just kept it at anxiolytics and antidepressants. In the next paper, where we're planning to look at out-of-pocket cost and government cost, for that one, we're probably going to stratify by a bunch of different groups as well. So we'll probably say, what's the costs associated with the hormone therapy, including anti-androgens? And we might do a few other breakdowns of different types of prescription medicines, GP visits, all other. I think we're going to basically look at the whole spectrum of out-of-hospital healthcare use in the next study as well.
Hi, I just had a question about the cost numbers, like the reduction in costs. Does that include the cost of providing the gender-affirming hormones, or is that just like the mental health?
Yeah, great question. No, so this is just the mental health care costs. So the next paper, we're going to include all the costs, and we look at the total costs. So it'll be GP services, specialist, endocrinologist, the cost of hormone therapy, everything. We're going to include it all, out of hospital services, prescription medicine separately. And like preview on that, I think you can guess it's going to be, there's a huge reduction in costs over time. So yeah, maybe hopefully I'll have some results to show you that soon. Public hospitals. Yeah, unfortunately not. That's a huge limitation. So this is for sure going to be a underestimate of the total costs. So I am hoping to work with Mo on this actually. So Mo is applying to get the 45 and up data, which will have hospital costs. So I'm going to try that. Otherwise, there's this other data set I'm trying to apply for, which is called the National Health Data Hub, and that will have hospital cost as well. And then PLIDA, the one that I'm using, they're supposed to include hospital records soon too. But you know, we ask them every week. I'm like, when's it coming? When's it coming? And they say, I don't know. So one day that will be included.
Yeah, one more. We spoke a little bit about this outside before, about whether there might be some groups that are systematically not included in the data, like temporary residents in Australia.
Yeah.
So,
yeah, exactly. So PLIDA misses a lot of important populations. So in particular, people experiencing homelessness as well, recent arrivals to Australia, incarcerated populations won't be in there. Anyone who doesn't have a Medicare card won't be in there. I think who else, but yeah, definitely limitations in the data, who's captured. Oh, how are scripts counted? That's just total number of scripts per year per person. Yeah.
All right. Thank you very much, Karinna. Everyone can see why I think she's incredible. Let's put our hands together for Karinna. Thank you.